All right, so part 2 of diabetes, I'm going to talk through a lot of medications here. Wanted to break that up some to make it a little bit more manageable. So as we mentioned earlier, type 1 diabetics all require insulin exogenously. Type 2, they may be able to use a healthy eating plan and regular exercise to maintain that healthy weight, and that might be able to keep them in that good glycemic control, meaning their blood sugar levels are good. However, most people with type 2 diabetes will require medication management because the nature of diabetes, it's just progressive in nature if you think about those causes that we talked about earlier. There are 3 major classes of blood glucose lowering agents: insulin, oral agents, oral hypoglycemic, and non-insulin injectable agents. Now, a patient with type 1 diabetes is going to require daily injections, frequently multiple injections 4 or more times a day, or they might be on a continuous insulin pump, which actually usually gives the best glycemic control where their blood sugar is better maintained. Type 2, they may not need insulin, but if they get severe stress, such as a bad illness or surgery, they may need insulin during that time. And again, over time, as diabetes type 2 progresses, they may have to add insulin into the regimen. So insulin differs based on onset, peak action, duration. It's categorized as rapid acting, short acting, intermediate acting, and long acting. And most patients are going to use this basal bolus regimen, which most closely mimics the way their body would normally handle things. So the rapid or short acting is before meals, and intermediate or long acting, that basal, is kind of that background insulin that's, not peaking as much. It's usually either once or twice a day, depending on which one that they use. It does require frequent self-monitoring, but there are some other regimens that can be prescribed based on the endocrinologist preferences and what the patient needs. So mealtime insulin, that bolus insulin, this manages that postprandial, again, postprandial just means after meals, blood glucose levels. The timing of the rapid and short-acting insulin with meals is crucial. So rapid-acting, such as Lispro or Aspart, have an onset of approximately 15 minutes. Some of them are even as quickly as 5 minutes. So we really want them to have that right before the meal so it's more like their body. Short-acting regular has an onset of more of 30 to 60 minutes and is usually injected 30 to 45 minutes before the meal. The timing may be difficult to incorporate into lifestyles, and rapid-acting is more preferred because short-acting has a longer duration of action and it can actually lead to hypoglycemia. And in my years of nursing, we used to use regular, and I can't tell you the last time I've given regular. We've really gone to those rapid-acting insulins in the hospital settings. Now, basal insulin is that long or intermediate acting. It's used to help maintain that blood glucose levels between meals and overnight. So without that 24-hour basal insulin, patients with type 1 diabetes are more likely to develop DKA. And type 2 patients who use oral medications may also require insulin to manage blood glucose levels. So the long-acting insulins that I would like you to be familiar with are Glargine, Lantus is the trade name you know it as, Dedamer, or Degludec. It releases steady and continuous. For many people, there isn't a peak. The typical action time is anywhere from that 16 to 24 hours, but it's used once a day. Dedamer can be given twice a day. The risk for hypoglycemia is greatly reduced since they lack a peak action time. And Glargine and Dedamer cannot be mixed with any other insulin. And I was working one day and found out that when you do that, it inactivates the insulins because of pH and all that. And so that's why you have to give separate injections for that. And then there are some medications that are mixture 70-30. And so that has 70 the Degludec, and then 30 is Aspart. And so that person may take a little bit less injections because of that rapid and long-acting mixture. So again, type 2 diabetics, if the oral agents are not adequate to get those glycemic controls, they may end up starting to add some mealtime insulin. So intermediate acting insulin, NPH, and I think of this as that cloudy one. This is also used as a basal insulin, and the duration is usually 12 to 18 hours. The disadvantage is it does have a peak anywhere from 4 to 12 hours, which can cause that hypoglycemia. However, NPH can be mixed with short and rapid-acting insulins. NPH, Lispro, Aspart are cloudy insulins because they contain protamine, decreases the solubility, and these insulins must be gently agitated before administration. And we're talking about gently agitated. We're actually talking about rolling that in our hands. In my experience, I've seen most patients who take NPH, they actually usually take it twice a day, in the morning and evening, 12 hours apart. So again, that combination insulin therapy, for people who only want to do a couple injections per day, they'll get that short or rapid-acting insulin mixed with the intermediate-acting insulin in the same syringe. That allows for that mealtime and basal coverage. It may be appealing to patients. However, patients may really get better optimal coverage if they actually do that basal bolus therapy that we talked about. Patients are able to mix their insulins themselves, or they can use a pen that's already pre-mixed for them. Pre-mixed offers less optimal blood glucose control, and they can be a little bit pricier. So students often ask me, do I need to know when the medications have an onset or peak? And the answer is yes, especially when you're thinking about your rapid and short acting. Because of the risk for hypoglycemia, we need to know when they're going to peak. So ideally, you learn this table from a safety perspective. Remember, NCLEX is all about you being a safe nurse. But if you're really struggling, you're really going to focus more on that rapid acting and short acting. So we want to teach patients about how to store their insulin. We don't want it to be in greater than 86 degrees or less than 32. It's going to make it less effective. Insulin vials and pens can be stored at room temperature for up to 4 weeks. So in the hospital, we usually write that 30 days. Needs to avoid sunlight. Can be stored in a cooler, not a freezer. And then any unopened should be stored in the refrigerator to keep it good until the expiration date. Syringes can be pre-filled depending upon the insulins, and they're stable up to 1 week. And then one insulin is stable for 30 days in the refrigerator. Again, we want to teach them to store syringes in the vertical position with the needle pointed up. Before injecting, they need to roll their pre-filled syringes to warm and remix any suspensions. And then not all insulin combinations can be pre-filled or stored, so they would have to check with their pharmacist or their healthcare provider. So regular doses of insulin are given subcutaneously. We can give regular insulin IV with an immediate onset. So that's one of those medications. Regular insulin can be given IV push. It is important, and obviously patients aren't going to be doing that. That would be us with somebody with DKA. It's important that we teach patients how to give their insulin subcutaneously. The abdomen is the preferred injection site because it has the fastest absorption, more than the arm, thigh, and buttocks, although they can use those other ones. We do want them to rotate injection sites within and between the sites. So most insulin comes as U100, meaning that 1 milliliter contains 100 units of insulin. It's vital that we use the right type of syringe when we give it. There are different sizes of syringes with different increments. One line might be 1 unit versus another syringe. One line is 2 units. So make sure that you're always looking at that closely. Never recap a needle. That goes for us as healthcare providers. We need to use alcohol swabs prior to injecting so we don't cause any infections, and it should be given at a 90-degree angle. So mixing insulin, this is another classic NCLEX style question. You do need to know how to correctly mix insulin. And so in this one, obviously we're washing our hands, but you're going to put your air into the cloudy, and then you're going to put air into the regular, and then you're going to flip that over and go ahead and draw out your regular insulin. Then you'll take that out, and then you'll stick it into the NPH and then draw out the NPH. So you can learn that as cloudy, clear, clear, cloudy, or the other way is Nancy Reagan RN, so N for the NPH, R for the regular, RN. Many of you may not even know who Nancy Reagan is, but she was one of the first ladies. Insulin pens, it's really important how to use this correctly. You just twist the little dial and it'll give the correct thing. It's a lot easier for somebody with vision issues. You do put new needles on each time you stick it on. It is more convenient and flexible, but they're single-use pens. You cannot use one insulin pen for another patient. No sharing, because again, there's a needle, then you take off that needle, so never ever sharing, even if you have interchangeable needles with those. And this is just an image of insulin pen. The needle, you twist this to get to the thing, which is the dial, and then the plunger. And I'll demonstrate in class the correct way to hold it and talk a little bit more about that. Now, insulin pumps, they do continuously deliver that subcutaneous insulin all the time. It does use rapid-acting insulin, which is into that cartridge. They are programmed to deliver and so it gives that continuous basal rate. And then they can also increase that to give a bolus during their meal times. And so they carb count and then they give themselves a bolus. And again, patients or friends of mine that I know that have the insulin pumps say that their hemoglobin A1Cs are much better. Now, when somebody has an insulin pump, the actual infusion set is changed every 2 to 3 days to prevent infection and to help again with changing that site, so the insulin absorption. The patient checks their blood glucose levels 4 to 8 times a day, and many of the pumps actually have that built into that, or they'll check it. Again, the advantage keeps the blood sugar in a better range. Insulin is delivered similar to normal way the body normally does that. The pumps are a little bit more flexible with the meal and activity patterns. Challenges, there can be infection at the insertion sites, increased risk for DKA if insulin infusion is disrupted. There is that cost of the pump and the supplies, and then being attached to a device. Pardon me, patients can only come off that device so long, like to go swimming. And so there can be some, disadvantages to it. This is an example of what it looks like on the patient, and then the pumps, and the pumps all varies how they look. This kind of looks like an old picture to me for a pump compared to some of the newer ones I've seen. And this is an example of where the injection is going in, and that's this B part here. And then this is where they're getting that continuous glucose monitoring all onto that thing. And so those are the ones that I see used more frequently. Again, potential issues with insulin hypoglycemia. We'll talk about that more in complications. There can be allergic reactions causing some itching, erythema, burning. It's usually self-limiting in the first 1 to 3 months. Changing to a preservative or latex and rubber-free stoppers can help with decreasing that allergic reaction. A true insulin allergy is rare. And then there's the chance for lipodystrophy, where they keep using the same site frequently, which causes some atrophy and wasting of the subcutaneous tissue, and that looks like a little indentation. Or there can be hypertrophy, where you see thickening of the subcutaneous tissue, and that will regress if the site is not used for 6 months. And again, these can cause an erratic insulin absorption if they're using a place that has that hypertrophy. So knowing the difference between Somogyi effect and Don effect, or dawn phenomenon, sorry, is important. And so with the Somogyi effect, they get a high dose of insulin, causes them to have a drop in their blood sugars during the night, usually like think about that 2 to 4 in the morning, which then causes counter-regulatory hormones to be released, which then causes hyperglycemia. So the way we would identify Somogyi effect would be checking that blood glucose between that 2 to 4 in the morning, looking to see if it's dropped. Patients may complain of headaches upon awakening or recall having some sweats or nightmares during the night. Making sure that they have a bedtime snack or decreasing the dose of the insulin can help to prevent the Somogyi effect. So whereas the dawn phenomenon is, again, they're going to have hyperglycemia when they wake up. This can be related to growth hormone or cortisol. It may affect the majority of the patients with diabetes, tends to be more severe in our young adulthood and adolescence. Treatment is to increase insulin or adjust the insulin administration time. Again, you're going to check the blood sugar somewhere between 2 and 4, looking to see if the blood sugar is high. If the blood sugar is low, then we know that it's the Somogyi effect versus the dawn phenomenon. Our blood sugar is going to be high at that time, and then we've got to change our insulin based on those. Now, there are inhaled insulin. Afrezza is a rapid-acting insulin. Would be given at the beginning of the meal or within 20 minutes after starting a meal. It is not a substitute for long-acting insulins, and you don't want to use this for DKA treatment or patients who smoke. It should not be used for patients with COPD or asthma because bronchospasm can occur. I personally never given an inhaled insulin. I think it would be cool to see, but in the adult world, I have not seen that.